It is my pleasure to introduce tonight's speaker, Dr. Jason Edwards, and he is out of St. Luke's Hospital in Missouri. And Dr. Edwards has earned his PhD in cellular and integrative physiology at Indiana University and proceeded to earn his medical degree at the University of Missouri and moved onward to a surgical internship and radiation oncology residency at the University of Kentucky's Chandler Medical Center. His expertise is focused on integrating sophisticated technology into successful treatments for cancer patients. And he has a special interest and is trained in high dose rate and low dose rate gynecologic brachytherapy, intensity modulated radiation therapy, stereotactic body radiation therapy, and image guided radiation therapy. He has been published extensively in peer-reviewed journals, co-authored oncology texts, and has been invited to give numerous lectures across the country. But I would be remiss if I did not highlight a couple things that were not included in this formal bio, and that is that he embodies what it means to be patient-centered. His respect and compassion for his patients is so evident, and this is true not just of him, but it extends and is pervasive in his staff. Patients love them. But that also means they're a really busy clinic, and balancing efficiency in a busy clinic with compassionate care and clinical excellence is daunting. And I have benefited so much from learning from his thoughtful and pragmatic approach. And I'm excited for you all to do the same. So with that, I will turn it over to tonight's speaker, Dr. Jason Edwards.
Thank you very much. And I want to tell everybody who's attending, thank you for your time and attention as we go through this talk. And if you have any questions, either write them down or let me know as we go along. Tonight's topic is breast cancer-related lymphedema. And I want to talk about why it's important, how we identify it, and how to develop a program to treat patients effectively to give them the best possible outcomes. Let's start off with why this is important. And I want to start off with a poll right from the top. Even with advances in breast cancer treatment, breast cancer-related lymphedema is prevalent what percentage of the time in patients? And we're only asking you questions that we think you'll get the answer wrong to, so there's a low threshold for success. So please hazard a guess. No penalty. All right, we're seeing them come in. All right. Looking pretty good here. Okay, so 3% said 0 to 10%, 11%, 11 to 20%, 42% was 21 to 30%, and 44% of patients pollers said greater than 30%, which is the correct answer. And so there are two studies. One was the Iowa Women's Health Study, and the second one was the Philadelphia study that looked at patients who had breast cancer-related lymphedema, and it was 30 to 40% of the time, which, to some, I'm sure is surprising. And this talk's not going to be full of polls, but I've got two right off the bat. What percentage of these patients out of this 30% do you think had truncal edema? And by truncal edema, I mean lymphedema of the thorax or breast, either independently or in addition to the upper extremity. Yeah, okay. Everybody's doing a good job here. Coming pretty accurate. And so we see the majority of people who did the poll thought that it was greater than 50%, which is the answer. It was greater than 50% of patients who had lymphedema had lymphedema of the breast or trunk. And this is important. Not only does it have an impact on patients' health, it can also have psychological impacts, which can be just as detrimental as the physical impacts. The lymphedema can contribute to poor cosmesis. It's an unexpected obstacle that patients can deal with in their cancer treatment, and it can have a real effect. And there's economic effects as well. we know that breast cancer-related lymphedema is oftentimes diagnosed late. And so I think we have a real opportunity here to potentially learn and change our practice to catch lymphedema at an early stage where it's reversible. I want to talk briefly about just the overall physiology of the lymph system. The lymph system has two main purposes. One is it plays a role in the adaptive immune response. You have B and T cells circulating through the lymph system that help transport viruses and bacteria to the lymph node so the body can develop an adaptive immune response. The second function is it maintains fluid homeostasis throughout the body. And so you have the heart that pumps blood to the organs and to the tissues. Most of that fluid and blood is picked up by the venous system and returned to the heart, but about 15% of it is not. And the body relies on the lymphatics to take up this interstitial fluid and transport it to the left subclavian vein and return the body to its normal homeostasis. So, and that's kind of a quick and dirty overview. Now, what happens or what factors can contribute to lymphedema? Well, with respect to breast cancer-related lymphedema, I'm just kind of going to go in the order of a patient's kind of normal procession through their breast cancer treatment. Cancer itself, if you have a big bulky lymph node that's impeding lymph flow, that's going to cause inflammation of the lymph system and can ultimately contribute to lymphedema. It's certainly going to challenge the lymph system. If you go in and you have surgery where you remove the lymph node, that's going to cause inflammation, and just the sheer removal of the lymph node is going to disrupt the lymphatics. And so you can have interstitial tissue inflammation, or you can have disruptive lymph channels that can contribute. We also know that Taxol-based chemotherapy is at least associated, maybe not causative role, but it's associated with increased lymphedema. And then certainly radiation therapy can cause fibrosis and stenosis of the lymph channels. And when the lymph channels are challenged, they have a difficult time maintaining the fluid homeostasis of the trunk or limb, which can ultimately lead to lymphedema. And then lymphedema itself has its own kind of pathophysiology. You have edema of either the affected organ, whether it's the limb or the trunk. And this can ultimately, if it's not taken care of or it's not addressed early, either in stage 0 or 1, you can have increased stress on the system, and this can lead to chronic inflammation, which can ultimately lead to fibrosis. Now, if the lymph channels have fibrosis and they're challenged again, now they're at a position where it's even more difficult to maintain fluid homeostasis. So now you're in a situation where you have a negative feedback loop. And so more inflammation, more chronic inflammation, more fibrosis, even that further decreases the ability of the lymph channels to maintain fluid homeostasis. And then you can get to a point where you start having skin issues. Patients have small cuts in their skin, which can lead to recurrent infection. And then you're in a position where you have a compromised immunity of at least the organ. And so the goal of treatment in any disease is to try to catch it early and treat it before it gets into this negative feedback loop. Now let's go over this. I kind of mentioned stage 0 and 1, and that's kind of stage 0 seems kind of like a weird concept. I mean, we see it with like ductal carcinoma in situ, but for lymphedema, what stage 0 means is that patients have symptoms, but it's not clinically evident. And so an example of this would be that you have some slight impairment of the lymphatics and their ability to maintain fluid homeostasis through the limb or the breast. And patients will report symptoms such as heaviness or tightness, tingling, or decreased range of motion. And when you do a clinical examination, it's just hard to see any pitting lymphedema or any clinical evidence of disease. But if this progresses, patients can develop lymphedema or edema of the extremity that's clinically apparent. And if it's stage 1, it's reversible, meaning that via massage or elevating the limb, patients can have resolution of their symptoms. And this is where we want to catch patients in the stage where the goal of treatment is reversal of symptoms, so patients can go on to live, a symptom-free, full, enriched life. If you don't address lymphedema at stage 1, over time, chronic inflammation will set in, which will lead to the fibrosis, which will lead to the compromised ability of the lymph system to maintain fluid homeostasis, and then you'll have long-term lymphedema. And importantly, once fibrosis sets in, you cannot fully get rid of the lymphedema. You can do things to minimize it, but you'll never completely get rid of it because the lymph channels have this fibrosis and stenosis, and they just don't have the capability to respond to a challenge. And then stage 3, again, the goal of treatment for stage 3 lymphedema is purely palliative. This is lymphostatic elephantitis. And if I'm being completely honest, in my training, I thought stage 3 was lymphedema and anything else was like something else. And this is like the picture you see from Robbins' pathology textbook, where there's, clearly an issue here, and it's reached beyond the tissue, and you start having skin changes, trophic skin changes, and acanthosis. And this is where you get into a situation where you have compromised function of the limb, and you can also have recurrent infections, and the body's just not able to deal with that very well. And so we got a second poll or a third poll here. Okay. In your practice, what percentage of patients are being diagnosed with lymphedema prior to stage 2, meaning that you're diagnosing patients in stage 0 or 1? And full disclosure, when I first started my practice, I just was not aware of the staging system and the implications of not catching patients at early stage. So in no way do I want to denigrate anybody. This is just about learning and becoming better, becoming a better doctor, and treating our patients with better care. And so getting some good feedback here. Okay. And so it looks like about 59% of you said 1 to 24%. And so, yeah, very good. Yeah, and like I said earlier on, I think we have a real opportunity here to improve our care of patients and catch lymphedema at early stage so patients don't have long-term issues. And so one of the keys to doing this is to develop a system or a heuristic, a method to evaluate patients who are at high risk and catch patients who have stage 0 and 1 disease. And it's kind of like the Willie Sutton joke. Why did you rob the bank? That's where the money's at. We want to find the patients who are going to be at the highest risk and really hone in on them, but also develop a system to kind of screen all patients. Now, with any screening program, it's a real balance between avoiding overutilization of care, but also catching patients early in their disease process so we can limit the extent of the damage to their body. And I think one of the things you got to do is you have to create some sort of system, some sort of protocol so you can avoid treatment gaps and really catch patients in those stage 0 or 1. And then you have a system that you and your staff know, like what's going to happen when you do diagnose with somebody with lymphedema and how you're going to intervene and get them treated appropriately and efficiently. And so you want to kind of define who has what roles. This was surprising to me. The NCCN has 2 different blurbs on lymphedema. One is in the breast cancer guidelines, and it says that that practitioners should consider pre-treatment measurement of both arms in patients with for baseline values prior to treatment, and especially in those patients who have risk factors for lymphedema. So pre-treatment is what they're recommending, which seems like a lot. And then they also talk about patients who are at risk. Who's that? We'll get into it. And then from the survivorship guidelines, they talk about detecting lymphedema at stage 0 and 1, where patients have minimally clinical or subclinical disease, which can be managed effectively, whereas stage 2 and 3 are less responsive to treatment. And so We want to detect this subclinical disease if possible. And we're going to talk about how to do that, how to detect stage 0 lymphedema. And a critical part of this is educating the patients to tell the patients what to look out for so they can report symptoms back to you so you can catch this at an early stage. So this is a study that found multiple risk factors associated with lymphedema, and they developed a scoring system to find patients who are at high risk, so you could kind of hone in on that. And you can do this, but you could also just know it and look for patients who have these risk factors. So you can be as tedious or as non-tedious as you want about it, or regimented, maybe a better word. So one of the metrics they use is something called relative arm volume increase, or RAVI. And this is when you take measurements of patients' extremities before treatment and after treatment and see what the difference is. And it's a complicated formula, but we can provide it for you. Another risk factor is BMI pre-surgery, and patients who have a BMI greater than 30 have an increased risk of lymphedema. And then these next three factors probably are confounding factors and run together. It's my best guess. And it's estrogen receptor negativity, lymph node positivity, and chemotherapy use. Now, they don't always run together, but they commonly do. And ER negative is a risk factor. The more lymph nodes you have positive is a risk factor, probably because the cancer impedes flow itself, but also the surgical resection is going to be to a greater extent, and certainly radiation is going to be to a greater extent. And then chemotherapy, if patients have taxane-based chemotherapy, they're at further risk. And so you can really see the more of these factors you get, you really get into a position where your patients are at very high risk for lymphedema. And we really want to hone in on these patients. Importantly, the study also found that on univariate analysis, radiation therapy is an independent risk factor, as well as advanced age and patient-reported symptoms. Now, this is important. Patient-reported symptoms such as hand swelling or tightness or tingling or pain or decreased range of motion, that's highly correlated with relative arm value increase. And in my clinic, I don't get relative arm value increases or follow this metric. Because it's so highly correlated to patient-reported symptoms, it's much easier on me and my staff. And we're all dealing with limited resources these days. It's much more efficient for us to follow these patient-reported symptoms as a proxy for relative arm volume increase. And this is a comprehensive list of patient-reported symptoms that correlate highly with relative arm volume increase. And this is how you detect stage 0 lymphedema. And you don't see it clinically, especially in patients who have these risk factors. They're going to be at 30 to 70% risk of some degree of lymphedema, and they report these symptoms. It makes it a chip shot to say, I'm getting this patient some either education or treatment or pre-treatment. And so it's arm swelling, heaviness, firmness, decreased range of motion, aching, numbness, any of those symptoms. And if you educate the patient that, hey, if you have these symptoms, you need to tell me so we can address this early and manage the lymphedema process at a stage where it's reversible. Without the education to the patients, they're just not going to know to tell you. And this is, I think, one of the most important slides of this presentation. And this is a patient who has lymphedema of the breast. I had a coworker bring me in when I was finishing my training, and he said, hey, this is breast cancer-related lymphedema of the breast. I'd always thought it was of the arm, like you see in the Robbins pathology book, but he said, no, it can occur in the breast. And that's what we see in the studies, that over half the time it's of the trunk or breast. And here you can see it's kind of a subtle pot orange where you can see the hair follicles, and they become more prominent when the fluid is in the subcutaneous tissue and it's causing that tissue to pooch out, so to speak, but the follicle stays in the same place. So then it becomes very prominent. Typically, you're going to see this on the dependent portion of the breast. There may or may not be some redness associated with it. And if you look at the contralateral breast, you won't see it. And so that can be your control. And so if you see this is breast cancer-related lymphedema of the breast. And this would be stage 1 or 2, depending on the severity, and this needs to be treated. in my experience, if you don't treat it, or if treatment fails, they will either have an increased volume of that breast, but more commonly, that chronic inflammation will lead to fibrosis, which will lead to, and especially with patients who have pendulous breasts, will lead to retraction of the breast due to scar tissue. And when you feel the skin, compared to the contralateral breast, there is significant fibrosis and firmness of that breast tissue. Now, some of that's inherent to radiation, but some of that's from breast cancer-related lymphedema. And that can be, the severity of that can be mitigated, which will likely improve a patient's cosmetic outcomes, so they don't have, breasts of two different sizes. And so whether you're using relative arm volume increase or you're using the patient-reported symptoms, I think you want to develop a system where you're asking patients or checking on these things in a kind of a regimented frequency. It's important to educate the patient early and maybe get measurements, but at least educate them. And then on their first follow-up and subsequent follow-ups, you continue to either obtain measurements or ask them these questions. Now you can have a mental checklist, you can have a physical checklist, but it's somewhat comprehensive, but it's, basically numbness, tingling, firmness, decreased range of motion, pain. Those are the main symptoms we're looking for to detect subclinical stage 0 lymphedema. And so now you've identified, you've asked the questions, done your clinical exam, and in some form or the other, you've identified a patient who has cancer-related lymphedema. What do? Well, you've educated them on the symptoms, and now you need to educate them on the disease process so that they can best care for it and understand that it's important that they care for it. And so you explain to the patient what lymphedema is. In my clinic, I send them to the occupational therapist because we have a lymphedema-trained occupational therapist who gives them even more education, shows the patient things they can do on their own to limit or reverse lymphedema, such as whether it's an elevation of the extremity or a massage technique or a stretching technique. It's important to talk to the patient about exercise, skin care, and what a small cut can do when it challenges an extremity that has lymphedema, and the decreased ability of the lymph channels to maintain fluid homeostasis when challenged, and the importance of, and just to try to avoid that by maintaining good skincare, a static compression sleeve for the patient. And then if patients have advanced lymphedema or lymphedema of the trunk, using a product like the Flexitouch Plus lymphatic stimulation and drainage system. And then in the third column here, we have, professional help, and usually it's a physical therapist or occupational therapist that's lymphedema trained. You can look up if there's a lymphedema trained occupational therapist or physical therapist in your area. And if possible, if you have a physical therapist or occupational therapist, if you can have them, have some sort of training too, and they can be treated in your own facility, I think that would be nice as well. And so I see the patient, say they have lymphedema of the breast. In my clinic, they're going to get a referral to our occupational therapist who's lymphedema trained, and they're going to educate the patient, but it's also going to be a referral at the same time to Tactile Medical, who makes the lymphedema pump. Now, Tactile is not going to just go immediately give them, the pump. They're going to help educate the patient too. And this is very helpful for occupational therapists. Is overrun. They can see the lymphedema rep from Tactile, who can also provide excellent education for the patients. And that's been my experience. It's been a real asset to myself and the patients, especially if there's a delay in care by a few weeks of getting them into the occupational therapist. In an ideal world, that doesn't happen, but we all know how things really work. Then they see the physical therapist or the occupational therapist, do some testing on the patient. And if they meet the criteria, then they may come back to Tactile and receive one of their products or not. This is really a loop, though, and a kind of a three-pronged clinical treatment paradigm where they see me, the occupational therapist, and Tactile, so they get the best overall care. And so what tools do we have in the toolbox to treat? Let's get specific about the things that we can do. There's self-MLD, which is manual lymphatic drainage, and that's stretching or massage techniques that patients can do anywhere and everywhere. Now, the issue with this is it's patient dependent. And of course, some people are going to be worse and some people are going to be a lot better at doing this for themselves. There's a static compression sleeve or wrap. And a lot of times where I use this is if a patient doesn't have lymphedema, but they're at high risk and say like they're going to on a airplane trip to Hawaii, like 3 weeks after treatment, which, seems to happen like shockingly more than you would think. I tell them, buy a $20, 20 to 30 millimeter mercury compression sleeve and wear it on the plane or put it in your bag. You don't want to end up in Hawaii and have your limb swell and, have nothing to do or not know what to do. You could also use an ACE bandage in a pitch too, to provide static compression. The next level of treatment would be a basic pneumatic compression device. And this is a sleeve with multiple chambers that inflate and deflate sequentially to massage gently and decongest lymphatics. And then you have something like the Flexitouch, which is an advanced pneumatic compression device. And this treats the limb, but also that truncal edema that we have in more than half the cases. And this is a multi-chamber. I think there's 32 chambers that are rounded, and they sequentially fill to gently massage the lymphatic fluid out of the limb, out of the decongested area or congested area to an area of the lymph, which is better at processing that fluid. And this is a picture of it here. You can see it's on the extremity, but it also is on the trunk. They also make a device for head and neck, which I use in almost all patients because 90% of patients develop head and neck lymphedema, but that's another story. But this goes beyond the hand. So it starts gently massaging and decongesting the lymph channels to push the lymph fluid up to the upper thorax where it can be processed and ultimately returned to the venous flow. The nice thing about this is it's hard to fail as a patient. It's consistent. All you have to do is basically strap it on and the rep goes over it with the patient. And so the results are very repeatable, and we have data on this that I'll show you. It's convenient in the sense that you don't have to drive to and from the occupational therapist to the physical therapist. This is something that you can do in the comfort of your own home. It's comfortable. It's a gentle massage, and that's all it takes to drain the lymphatics. It's a soft garment, and it gives dynamic sequential pressure, kind of like a soothing massage. It's comprehensive in the sense that it treats everything from the hand to the thorax, and it's clinically proven. And let's get into some of that. And so here we see a near infrared fluorescence lymphangiogram where this proteinaceous fluid is injected into the wrist, and you can see that the pump circulates this protein from the wrist to the elbow to the axilla. And so it's effective on the tissue scale. And then we see when we look at the metrics of weight loss and edema volume in a randomized crossover trial that the Flexitouch Plus is superior to self-manual lymphatic drainage significantly. And then importantly, and this is what I see in my clinic as well, patients don't hate this, especially if they, the further along their lymphedema is, the more they appreciate this. And it was somewhat surprising to me that sometimes a patient a year out or even 2 years out, if they have significant lymphedema, they continue to use this. And patient satisfaction has been high in my anecdotal experience. And also this is what we found in the trial. And importantly, it continues to control lymphedema in about 95% of patients. And so one thing I do see is over the course of, say, many months, patients begin to use this device less often. And I think that's a function of the success that it has with the patient in reducing their limb or truncal lymphedema. And so they may start off, using it daily, say, and then switch to twice or every other day, and then once every 3 days, and begin to space it out. And they know that if they get behind or they start to develop recurrence of the lymphedema, that they will begin using it more aggressively and then slowly start to space it out again. Importantly, in patients who have cancer and patients who don't have cancer, we see improved outcomes with regard to cellulitis outpatient visits and hospitalizations, and importantly, cost is reduced. And so I think this is really a winner all the way around. If we can save on costs, have better patient outcomes, and this is recommended by the NCCN, we have a lot of good reasons to treat lymphedema early and aggressively, and to have an overall better outcome for your patients. My clinical experience, one of my fellow radiation oncologists, his sister was a lymphedema trained physical therapist. And I think she probably educated him, and he passed it on to me and said, this is really important, and it probably goes underdiagnosed a fair amount of the time. And so he, kind of cajoled me into making this a part of my practice so I can give my patients the very best care, which is what we all want. And so since then, I've kind of, and I had my PhD's in vascular physiology, so I kind of had an interest in this as well from a scientific standpoint. But I think it's a good thing to treat lymphedema early and aggressively. It's certainly not in all of our patients. It's not even in the majority of the patients, but you do see it. And I think it's, that 30 and 50%, 30% of patients have breast cancer-related lymphedema, or 30 to 40 based off the two trials. And half of those, or over half of those, have truncal lymphedema of the breast. I think those are two important numbers to keep into your mind. You really need to look out for that lymphedema of the breast, not only for the patient's overall health, but for better cosmesis, better physical and psychological health. And with that, Sarah, are you there?
I am. With that, we will move on to some Q&A from the audience. So just as a reminder, if you have questions, please submit them through the Q&A icon at the bottom of the screen. If you submit them through the chat, they are more likely to get missed just because we have a lot of questions that come in. So Dr. Edwards, thank you so much for that presentation. I always find talking with you so informative. We do have some questions right off the bat. First question is, do you think that changes in treatment pathway, so either earlier diagnosis or changes in actual treatment, are increasing the number of patients with that truncal or breast edema, or are we just identifying it more often and it's always been there?
I think the latter is much more true. I mean, they both may be true to some extent, but there's been obviously a real move to become less aggressive with lymph node dissection. Maybe one thing I didn't say is I detect, in my experience, lymphedema, and we treat a lot of patients with breast cancer, detect lymphedema typically after surgery and before radiation or during radiation. It can certainly happen afterwards. And I don't have any good data on this, but that's been my anecdotal experience. And there's certainly been a trend to decrease the extensiveness of lymph node dissections. And so I think probably less so on your first question and more so on the second, in the sense that we're detecting it early, education's getting better, we're fine-tuning how we're treating breast cancer, we're improving not only the cancer treatment, but also the side effects or the ripple effects that patients have from the treatment. And we see that in chemotherapy too. Patients do better with chemotherapy than they did 10 years ago. I'm sure hospitalizations are significantly less than they were 10 years ago. And I think it's just part of the evolution of us continuing to push ourselves to be better and give our patients the very best care we can. And so I think it's probably more the latter.
Thank you. This person asks if you ever refer to surgery to resolve lymphedema, lymph node transplants, et cetera. Do you ever refer patients for surgical interventions?
I have one patient, and it actually wasn't a patient of mine. It was somebody I know. I don't want to get into too much detail, but I knew from a personal standpoint, and they had significant lymphedema that was stage 3, horrible lymphedema. And they came to me and said, "Hey, I'm in real trouble here, and what can I do?" And I can't remember the doctor's name, and if I did, I would tell you. It was a guy in Chicago. And he was a specialist at it, and he did a lymph node transplant. But it's, when you get to that point, there's so much. I mean, you can do transplants, and you can do surgeries. and it may help to some degree, but the entire limb has so much inflammation and fibrosis that there's no way that you're going to be able to, completely reverse something like that. And so I think in dire circumstances, you want to do something like that. But typically, especially for stage 0 and 1, usually if you treat it aggressively with an advanced pneumatic compression device, that's typically going to do the trick. If it's beyond that, I typically continue to use the pneumatic compression device and only in the worst circumstances do the surgery.
Thank you. This person asks, if you're speaking to a colleague, another radiation oncology, and they kind of say, I'm not really looking for lymphedema because I'm not seeing it this early in the patient's treatment pathway, that's on the med onc. How do you think about that?
There may be a couple components to this. There's an old saying, if you know everything, you'll never learn anything. And there's plenty of that in medicine, and I'm probably guilty of it too. But I think some people don't want to look for it. And the truth is, you see the patient multiple times during their treatment. You should assume that you're doing a better clinical exam and seeing the patient more often and more thoroughly than anybody else. And I think the reason we got into medicine was to help people. And if you see it, I wouldn't depend on anybody else to take care of it but myself. The burden and responsibility to take care of our patients falls firmly on every doctor they have on their shoulders. And so the way I look at it is, if I see anything, I'm going to take care of it the best that I can, unless I think somebody can take care of it better or address the issue better than me. So that's my take on it.
Thank you. This question asks, at what point do you consider edema to be lymphedema? So for example, if it's 1 month post-treatment or 3 months post-treatment for your last radiation treatment, does that differentiate how you think about what that swelling is?
So I would consider edema, say somebody was 2 weeks post-op and they had some fullness in their axilla, or in their the skin overlying their humerus. Right off the bat, I probably wouldn't treat them. I would say, let's watch this for another week or two. But if you have chronic inflammation of a limb for 4 weeks, you're going to start to develop fibrosis. So certainly there's a temporal aspect to this. Typically in my clinic, the soonest I'm going to see somebody post-operatively is probably 2 weeks. And so if that hasn't resided by the time they've received their simulation or started the treatment, then at the very least, I want to assume that this could be lymphedema. And because I have a lymphedema trained occupational therapist, it's easy enough for me to educate the patient, to some degree, and then send them to the occupational therapist for further education so they at least know what to do to mitigate their edema. And so I think you want to err on the side of safety. And if you don't know, take the conservative route. And I realize that I'm fortunate to have a lymphedema trained occupational therapist, and that makes a huge difference. But that's what I do. If we're 3 weeks post surgery and there's still edema, I start to become concerned that this is going to be more of a chronic issue if I don't address it.
Thank you. This person asks, they say, we have a lymphedema program through our cancer center, but we struggle to get the surgeons on board with referrals. They do have a trained lymphedema therapist. Any additional thoughts on that other than what you shared prior about your perception of taking responsibility for the patients that you're seeing? Well,
this question has a lot of landmines to it. My wife's a surgeon, and they have in general a different mentality. I think we don't want to talk about feelings and gut instincts. I think hard data is probably the best way to move forward in this scenario. And if you can whether it's you or somebody else or your occupational therapist, do a presentation and just talk about the data from the Iowa Women's Health Study and the Philadelphia study. And there are other studies out there too that show that the rate of breast cancer related lymphedema is 30%. I mean, they may not want to acknowledge that, but that's the data. And certainly data can be flawed because human beings are involved in obtaining it. But I mean, when you have multiple studies over multiple time periods and multiple locations showing all about the same thing, this gives you more credence to maybe this is what's going on. And so I would just try to kind of address it in a non-confrontational way, in a factual basis, and just say, if we don't start treating our patients with best of care, we're doing a disservice to them.
Yeah, that's wise. We have a few questions about use of compression in this patient population. So the first question is, do you think that all patients should use some compression to prevent edema and lymphedema, regardless of how high or low risk they are?
That's a good question. I think before I would do anything like that, I would look for some clinical data that would support that. And that would be an interesting study. And there may be something out there. I'm not aware of it, but there may be something out there that supports that. But I think like stretching and massage, things like that, I'm all in favor of that. And I think that gives patients better range of motion and cosmetic outcomes, even because like my veterinarian says, after surgery, dogs do too much and people don't do enough. And so anything we can do to increase some sort of activity, whether it's stretching or exercise and things like that, I'm in favor of. But as far as going on to a compression sleeve, I think I would want to see some sort of clinical trial and some sort of evidence basis for something like that. I don't think that there would be an adverse outcome, but you never know. But that would be an interesting study to do, and I think it would be very publishable. So I promise I won't steal it. Take it and run with it.
All right. This question says, they say, I am a PT CLT LANA. I see my role is to help patients reduce their risk of lymphedema, but I always tell them I cannot prevent it. I also tell them that lymphedema requires lifetime management and that we cannot reverse it. We may get symptoms under control enough that treatment is minimal to none, but her lymphatics are always compromised and she needs to be aware of this. It is not cured. Do you agree?
Yes and no. So I sound like a politician now. If there's vascular systems have the capability to recover. So if you have stenosis or fibrosis of a vascular system, they do have some capability, whether it's arteries, veins, or lymphatics, to recover in time. Whether I don't know about collateral formation in lymphatics. I'm sure that happens to some degree, but you can have remodeling of the lymphatics. But if you have significant fibrosis, you're exactly right. It's never going to be the same. And I would say you're probably more right than wrong, but the question is on what order of magnitude. If you have an insult to any organ, it may not, completely function as good as it once did. But I do believe that stage 0 and stage 1 lymphedema is reversible, and patients can go on and live a long and full and symptom-free life if it's addressed at that time point. I think the issue is, we're focused on a lot of things. We're focused on treating the patient's cancer. We're focused on their psychological impacts. And I think just lymphedema has been one of those things that's on the back burner and it's just been neglected to some degree. And I think we're kind of reaching the point in the evolution of cancer care where it's starting to become something we're paying attention to because we're getting better at paying attention to the other, or taking care or addressing the other issues in cancer care. And so I agree. Once you damage any vascular system, it's not going to be the same, but I do still think you have an opportunity at stage 0 and 1 to reverse symptoms where patients have a high probability of living a symptom-free life once it's addressed.
Appreciate that nuanced answer. This person asks, for trunk and breast lymphedema, what type of compression works best? I'll add to the question. I think they're asking, are you using static compression for that outside of Flexitouch?
I'm not. I go straight to the advanced pneumatic compression device. It's hard. Like a static compression device, it doesn't like direct flow, and the lymphatics are very much similar to the venous system in that they have unidirectional valves, and so you want to push the fluid up towards the top of the thorax to healthier tissue where the fluid can be processed and you can maintain fluid homeostasis. Just kind of pressing on the chest or giving static pressure to the chest really doesn't, it's going to kind of maybe push it in to some degree up, but not to the same degree that the sequential compression is going to do. And I don't know of any good data with static compression of the thorax, whereas we do have excellent data with advanced pneumatic compression device.
Thank you. This person says, I noted in your bio that you treat gynecologic patients. Do you also see lymphedema in your gynecologic patients?
So 20 years ago, the answer was yes, because the lymph node dissection was aggressive. They would take out 20, 30, 40 lymph nodes, and you don't see that anymore. They're actually beginning to do sentinel lymph node biopsy for patients with endometrial cancer, which is excellent. And fortunately, it's just not something I see very often, but you do see it. And it's the exact same process. You want to get on it early and treat it effectively, and it can be very life altering for patients, and especially in the lower extremities, which is completely dependent at all times, whether you're sitting down or standing up. So that can be an issue as well. But fortunately, we don't see it nearly as much as we used to. Even with aggressive radiation therapy to the pelvis, you just don't see it as often. It's there, but not to the same degree. So we're moving in the right direction and have had more success with that than we have with breast cancer-related lymphedema.
This person asks, when patients start using the Flexitouch device less, is lower and PRN use a sign of success, or do you view it as non-compliance?
I view it as a sign of success, but I'll say this: the patient population that I treat is very compliant, and so and I've worked in areas where the patient population is not compliant. So just because that's the case for me may not be for you, where you treat patients. So I'm kind of biased because my patient population listens to almost everything I say, and that hasn't always been the case. And so I view it as success because I know that if they see that it's kind of, if they get behind on it, that they'll increase their regimen. And the other thing too is, they're trying to find balance in their life. And if they feel like they can, go a few days without using it, I'm okay with that. I don't want to be too rigid on them, especially, once they have been educated to know what they're doing.
This person asks, is your practice utilizing bioimpedance or LDEX numbers to diagnose or surveil for stage 0 lymphedema?
We're not. And it's, you have a manpower issue in clinics these days. And we just don't have the capability to do that. And it would be nice, to have these more advanced detection methods, but we just don't. And I think for a lot of clinics, it's just not the reality. Some will, and that's awesome. I think we want to, give the patients the very best care we can and mitigate the treatment-related side effects as much as possible. So I think it's a good thing if you can, but I do think that the patient questionnaires, we know that correlates highly with relative arm volume index, and I think that's a reasonable proxy for many clinics.
Thank you. This attendee wants to know, what do you suspect is the leading cause of under or misdiagnosis of lymphedema in the cancer community? For breast cancer or head and neck cancer, do you think it's a lack of awareness and education, a lack of research? What? Speculate for us.
Yeah, I think probably lack of awareness and education of the practitioners. Um, and I don't say that to denigrate people. We're all fools at one point, right? And there was a time where I had, no idea what it was. And that's the whole purpose of this, is to try to kind of educate and learn on how to be better doctors and forgive ourselves for our past transgressions. It's an evolution, and we've been focused on treating cancer, and there are multiple factors that you're trying to address in clinic, the psychosocial issues, the psychological issues. And I think as we do better on that, we're getting towards lymphedema, and hopefully we can see more and better education and better treatment of lymphedema in the future. And that's a positive.
Perfect. I'm about to reveal myself as an uneducated moderator, so forgive my mispronunciation here, but this person asks if you ever used drug treatment like benzopyrones.
I have not. I don't have any experience with that.
Perfect. Let's see. Going through questions here. This person asks, in the patient risk stratification, it mentions positive lymph nodes and not number of lymph nodes removed. Can you speak to this?
In the correlative study, it was okay. I see what you're saying. My guess is there's a high concordance between the two. So you're saying that it was the difference between the number of lymph nodes with cancer and positive lymph nodes. That's a confounding factor, and so it's more of an association. Is my best intuition, because the more lymph nodes you have, the more aggressive your chemotherapy and certainly radiation therapy will be. And so it may be, but my guess would be the number of lymph nodes removed. There's data out there that supports that that's highly correlated to lymphedema. And the number of lymph nodes that have disease is probably more of a function of the extent of surgical resection, chemotherapy, and radiation therapy. So I think there's some kind of confounding factors in there. But I think all of the above, the more aggressive you are with any of those things, the more likely you are to have lymphedema. Okay. The likelihood in those patients are going to be high.
Sure.
You should almost be looking for a reason not to see a specialist.
This person asks, what is the best way to treat and address post-radiation burns with a patient that has lymphedema prior to radiation therapy? So they came in for radiation already with lymphedema. How would you help manage their post-radiation burns?
Yeah, that's tough. Where I see this is when patients have post-operative seroma cavity infections or surgical incision site at the axilla, when they have an infection there. And the likelihood of them developing lymphedema of the breast with a seroma cavity infection is high, very high. And so now you've got all sorts of problems. And you treat them with an antibiotic. You try to do everything you can without doing anything surgically, going back in and cleaning it out. So I usually treat them with antibiotics. They develop lymphedema and they're going through the radiation therapy. And that's a tough go. That is a tough go for patients. I try to, and all my patients, I have them start moisturizers on day one, just not 2 hours before treatment. Have them drink a lot of water and do everything we can to mitigate the skin reaction. But sometimes you're in a position where you have to treat them both. And then if they have overt erythema and peeling of skin, usually I give them Silvadene, and we have to take some sort of break in the lymphedema pumping over the affected skin. I typically don't get too aggressive with that and say, we've got to take a short vacation, whether it's a week or two from any kind of pump until the skin heals. Depending on a patient's stage and things like that, you may want, you could decide to on the fly to omit the boost phase of the radiation if they had like lower grade disease or something like that, just to mitigate the short-term skin side effects. But obviously that can be a complex decision. But that's challenging, and I don't think there's any easy way through it. I think you got to make a judgment call of when to pull back on the lymphedema pump, but you can still do stretching and like gentle massage to some degree. But you've just got to wait for that skin to heal over.
That's helpful. Thank you. This person says they're treating a patient now with stage 3 lymphedema of the arm and trunk, so already elephantiasis, and this patient now has mets to the lungs and lymph nodes. The patient came to her already with a Flexitouch pump that no longer seems to be helping. Any thoughts?
Yeah, once you get to stage 3, it's trying to palliate symptoms as much as possible, mitigate infection, and it's very difficult. It's just when it gets to stage 3, it's just very difficult to rein in. And the idea of going to a surgeon to do a surgery on the lymph channels, that can be effective to some extent, but in this patient, it just doesn't seem worth it if she has visceral metastasis. If it's oligometastatic and slow growing, maybe consider something like that. But the success rate with that, even with stage 3, is not going to be high. And so, somebody else may have a better answer than me, but I think to some degree, you've got to face reality and accept the fact that this is going to be something that they are going to have to contend with in addition to their metastatic breast cancer from here on. You just have a very, very difficult time reining in step 3. You can try to palliate and mitigate symptoms as much as possible, but typically it's this negative feedback loop that just continues to get worse and worse. And you only have to have about one patient practice like this to make you really, become very aggressive at trying to diagnose stage 0 in one disease. But that's a sad case.
Yeah. This attendee asks, I learned usually pumps only work to remove water and they leave the protein behind. So the circle never really ends, causing proximal edema. What is the advantage of Flexitouch?
Well, the slide with the lymphangiography shows that actually can help move proteinaceous fluid up the extremity. Certainly with increased protein levels in the interstitial fluid, it's going to change the osmotic pressure inside the lymph channel, which can lead to more distal edema. But the Flexitouch can help propel not only lymph fluid but interstitial fluid up the extremity. So I think that's the advantage of the device.
Thank you so much. I do just want to acknowledge, to be respectful of everyone's time, that it is 8:00 and Dr. Edwards has agreed to stay on for a couple more minutes for a few more questions. But in case you do need to drop off, I just want to extend a thank you to everybody who took the time out to learn with us this evening. And with that, we'll just answer a couple more questions and then we'll let everybody go. This person asks, can you explain how sometimes lymphedema causes the body to develop increased fat deposits? And if so, how do you determine if lymph volume is more fluid or solid?
Don't know about fat deposits. It can cause kind of a bulkier interstitial fluid in its late phases. And so what you have is just like stasis of the lower extremity. The body is just unable to remove that fluid, and so it fills in to whatever kind of tissue you have, whether it's in the extremity. And so your subcutaneous tissue fills with fluid. But as far as like fat deposits specifically, I don't know of anything like that. So sorry, I may be ignorant of that. That may very well exist, but I'm not aware of the lymphedema causing fat deposits. Like if there's any adipose tissue, it may like increase the volume of that tissue, just by having like sheer fluid in that tissue. But as far as like increasing the fat content, I don't know, like that. But like I said, I that may be beyond my understanding.
Sure. This person also asks, do you see chemotherapy patients developing lower extremity lymphedema regardless of where the primary tumor was? Well,
I don't see that, but the scenario where I would see that could occur is, that many people are living in a very inflamed state, whether it's due to lack of exercise or diet. And so if their system is challenged in some capacity, and that could be through chemotherapy, it could also be from immobility or lack of movement during a difficult treatment. It's not uncommon to go through a difficult treatment and you're run down, your energy level is not good, and so you do less. And you can see patients, they can reach a negative feedback loop where their stamina is compromised, and so they're doing even less. And just from inactivity alone, in a potentially already inflamed body, systems become compromised. And that's vascular systems, but that's any system. And in general, your health is your blood flow. And so with inactivity, which is understandable, I don't chastise the patient. You're going through something difficult and you don't feel like going for a walk or a jog, but it decreases patients' overall movement, and it can increase kind of a pro-inflammatory state. And with that, it can tip the balance of fluid homeostasis where you begin to develop lower extremity edema due to venous stasis. And less likely, pure lymphedema.
Thank you. That's helpful. I know you had mentioned previously, some of those risk factors like taxane-based chemo. It's really, probably a compounding factor, not necessarily causal.
Yeah, like a good rule for medicine and science is everything's a lot more complex than you think it is. And
yeah. That's good life advice in general, I think. Okay, so let's wrap up with maybe one final question. This person says, I heard you say you work closely with an OT when you're educating patients on obtaining compression sleeves in a pinch. Who is educating them on over-the-counter garments? Is that you or the OT?
Usually it's me. The OT probably does a lot too, but say somebody's like, when I'm doing it, if it's like on the fly, or they say, hey, a patient will call me and say, hey, I'm traveling here. Is there anything I need to know, or something like that? And usually I just say, I would get like a 20 to 30 millimeter mercury compression sleeve, just to take with you on the airplane or on the trip, or in a pinch, get an ACE bandage and just, wrap it around your arm, kind of MacGyver it to some extent. But our occupational therapist, I got to say, is unbelievable. And she will spend an hour in educating each patient, which I know is unique. And so, and she knows more about lymphedema, than I've ever learned. There's no doubt about that. And so I'm sure she goes over all kinds of things, but I try to give them, some practical education as well.
Perfect. Well, thank you so much for the presentation tonight, which was extremely informative, as well as your thoughts and insights. This has been really helpful, and I know the feedback in the chats and the comments has been really positive so far. I just want to thank everybody for their time and taking time out of their evenings. As a reminder, Tactile Medical has a couple upcoming virtual learning opportunities. First is interactive clinical cases, so edema management for the vein specialist, and that is happening on Thursday, April 29th. So just a couple weeks from now, with Drs. Thomas Maldonado and Zoe Deal, as well as Dr. Tony Gasparis. So, and then coming in May, we actually have the supportive care and rehabilitation for head and neck cancer survivors, which is a continuing education course. I know that there are PT, OT, RN, and ASHA SLP credits available for that one. So check out tactilemedical.com/learning for registration links for those webinars, as well as previously recorded webinars, including this one in just a few days. And with that, I will thank Dr. Edwards again for his time.